So, welcome back, everybody. My name is Theresa Maral, and it's a pleasure, as always, to have you here back at this melanoma series in Medscape. And we will finalize this series of where should we go or what's next in terms of immunotherapy in the adjuvant setting by looking into the two other aspects that we need to consider when we discuss the fact that there is no overall survival benefit or there is no data on the overall survival benefit for patients treated with immunotherapy in the adjuvant setting. We discussed the first one, which was the fact that there might be some discussions or some uncertainties in terms of the reimbursement because this data is not available and might only be available in 2028. We also discussed a number of patients that are needed to treat to prevent a recurrence, especially when we are talking about stage 2. And we also discussed about the fact that this might lead to some uncertainty, both from the treating physicians and the patients, when they need to decide whether they will receive adjuvant therapy or when they will offer adjuvant therapy to their patients. The final point that I would like to bring to you to the discussion is that this uncertainty might lead to a potential shift by using target therapy instead of immunotherapy in patients that have a BRAF V600 mutation. And why is this the case? So we have data provided by the COMBI-AD study that investigated target therapy, in this case dabrafenib and trametinib, in patients with BRAF V600 mutated melanoma. And we saw that similar to what we see in immunotherapy, there is a benefit in terms of relapse-free survival and distant metastasis-free survival benefit. What we did see also was that there was no overall survival benefit for the whole population, but there was a higher benefit in terms of when we look numerically at 3, 5, and 7 years, especially for patients with BRAF V600E mutation. It came as a surprise, I would say, that patients with BRAF V600K not only didn't benefit from target therapy in the long run in terms of overall survival, despite having a benefit in terms of relapse-free survival, but when the overall survival analysis was conducted, what we saw was actually a detrimental effect for patients with BRAF V600K when we compared the treatment with placebo. So for these patients, we should not provide adjuvant therapy with target therapy. When we compared target therapy with immunotherapy in a real world setting, and this will be the topic for our next series, we will see that patients that had received target therapy might have a better benefit when we look into relapse-free survival and distant metastasis-free survival compared to patients that received immunotherapy. And here I'm only talking, obviously, about patients that have a BRAF V600 mutation. Finally, because target therapy is an oral therapy, some patients may prefer this therapy compared to immunotherapy that is given intravenous in the hospital. So we see 3 points that might be associated with the absence of data on overall survival benefit for immunotherapy. And just making a summary, the fact that there might be some reimbursement discussions that are associated with this aspect, the fact that in some cases, despite this therapy being recommended in the guidelines, there might be some uncertainty from the doctors and the patients on receiving and on proposing this therapy, and then a potential shift in the use of target therapy in favor of immunotherapy for patients with BRAF mutated melanoma. So we would ask, if we don't have overall survival benefit, why are we recommending this therapy? What is the benefit of having a relapse-free survival and a distant metastasis-free survival benefit? Well, I would argue that for the patients, this is quite an important event. We have shown that diagnosis of recurrence is one of the most important, or the aspect that most impacts the quality of life. When the patients are diagnosed with a recurrence, the quality of life decreases significantly. This data was, for example, mentioned during the COMBI-AD quality of life analysis. Obviously, the fact that the patients live longer without disease might provide them access to new therapies that are currently being investigated but are still not available at the time that they have been treated with the adjuvant therapy, but might be available for them if they live longer without recurrence. In real world data, we also see that approximately 50% of the patients that are diagnosed with stage 3B melanoma will be diagnosed with metastatic disease. And although in some cases we might be able to provide surgical resection, neoadjuvant therapy, or other local therapies, such as radiotherapy, for example, the fact that some cases patients will be irresectable or will be diagnosed with metastatic and inoperable stage 4 melanoma, it's quite important and is in some cases associated with a worse outcome. So longer time without evidence of recurrence, it's important and might lead to a better outcome in the long run. So, in conclusion, from our discussion so far, what we can say that trial data that we are eagerly waiting, and this mature trial data, it's necessary. And in the meantime, we might be able to use real world data to compensate for that and to analyze and to maybe inform the way that we use PD-1 in the real world setting in our daily practice. When we look into the absence of overall survival benefit, we also need to consider the access in terms of therapies post recurrence. When the patients recur, they might have access to all the approved therapies or not. And this also highlights the importance of deciding what is the kind of control arm that we use when we design trials in the advanced setting, because depending on the type of control arm and the access to the patients to these type of clinical trials, we might influence the overall survival benefit in these cases. There is currently a dual strategy for treating patients diagnosed with stage 3B or higher melanoma. And this might be neoadjuvant therapy if we have a macroscopically diagnosed disease, or it can be adjuvant therapy if we have a patient that has microscopic disease, and therefore, so far, it's not candidate for immunotherapy in the neoadjuvant setting. These type of patients would be around 40%, we expect, but also there will be some patients, there will be the patients diagnosed with stage 3A and patients with stage 2B and 2C that will be candidates for adjuvant therapy. Finally, the absence of overall survival data, but also the presence of relapse-free survival and distant metastasis-free survival data associated with the toxicity profile of these therapies, it's important to be discussed, and it's part of the shared decision in terms of the treatment that these patients can be offered at this time point that we are discussing. And with that, I thank you for your attention, and I look forward to see you again in the near future. Thank you.